So good morning, everybody. Hope you're all refreshed after your coffee. I'm going to spend about 40 minutes now talking about what's new for knee replacements. There's actually quite a lot to discuss and quite a lot to get through, I think, in 40 minutes. It's still controversial, I think it's fair to say, what's best for knees. But we'll do our best to kind of discuss some of the issues surrounding this. And talk about blocks versus local infiltration, which is obviously quite topical. I thought it was going to be very easy to give this talk, actually, because this is Rapham from December last year, so very, very current and up to date. And here we go. We've got a huge review. Anaesthesia and analgesia, practice pathways, options for total knee arthroplasty. So I thought I was just going to be able to sit in my kitchen, read through this, and then just kind of cut and paste it all out for you. So that's what I started to do. So here's Rapham. But reading through it, just at the introduction, they say it becomes immediately clear that the pathways are not standardized either in Europe or North America. This is an ASDRA and an ESRA joint review. And the panel quickly determined that it was going to be impossible to define or compare a specific pathway. So that's not a desperately promising start. And then they go on to say that rather than this being an absolute guideline, it's intended to provide a scoping review for specific components of knee joint pathways. So although I'll refer back to this at certain points, and I certainly recommend that you read it. It's almost so general and gives nods to so many different types of procedures that it's not hugely helpful, I don't think. Just to get it kind of out of the way at the beginning, this is their sample multimodal analgesic joint pathway. This is what they recommend. So just starting from the top up here, there's a preoperative holding area. There's nothing dramatically controversial there. I don't think they recommend paracetamol and non-steroidal and considering giving some oxycodone beforehand. It might be just worth just mentioning gabapentin possibly at the beginning. It's very, very commonly given for knee arthroplasty and hip arthroplasty. But there's actually very little evidence. They cite 3 papers, 2 of which are to do with chronic pain, and they're to do with limiting the amount of chronic pain that you get after a knee replacement, and one's an animal study on acute pain. So when it comes to acute pain for knee replacements, there's very, very little evidence that gabapentin's effective. Intraoperatively, they come down very heavily in favour of spinal anaesthesia rather than a general anaesthetic. There's lots of evidence to say that across the board in high-risk patients and in lower-risk patients, then spinal is probably the best way to go for knee replacements. Is anyone doing GAs regularly for knees, or does everyone do spinals pretty much? Anyone do GAs?
We've got kind of mixed practice, so
yeah.
colleagues do GAs.
It does come down heavily in favour of spinals. That said, they do give this caveat of specialist centres doing GAs get very good results. So it's not to say you're completely out with the practice, but they do heavily favour spinals. And after that, it's consider peripheral nerve blocks, consider local infiltration, and everything else that you can come up with. So if it's a starting point for a pathway, it's reasonable, but it's not massively helpful, I don't think. So I wanted to kind of address the elephant in the room. Has anyone worked up at Northumbria? So you'll know now Professor Mike Reed, this was a slide that Joseph, my son over there, did for me. He'll put anyone's head on any picture you like. So if for a small fee, he'll do that for you. It's quite good, quite useful. And Mike's pet thing is LIA, local infiltration analgesia, and they get very good results by just infiltrating local anaesthetics. So this is something that we've got to consider when we're thinking as regional anaesthetists. Should we be blocking, or should we just be saying, no, we'll just leave it to the surgeons, we'll just let them infiltrate. So I'd like to just briefly go through some of the background to the local infiltration story. This was the paper that kicked it all off. This really is in 2003. And they had two groups. There were fewer than 20 patients in each group, so it wasn't a big study by any means. If you look at the morphine group, they got actually a very small infusion of morphine, whereas the ropivacaine group had local ropivacaine infused into the wound. But both got 10 milligrams of morphine, so they both got 10 milligrams of morphine. One group got local anesthetic, and the other group got very little else. And so, not surprisingly, the study came down in favour of the group that was having local anesthetic infiltrated. We then skip forward a little bit. So this is 2011, and Colin McCartney and Gray McLeod reviewed 20 further studies. Only 4 of them compared local with regional. The rest were local versus placebo. And of these, only 2 of them looked at femoral block. The other ones were epidural, which I don't think many people at all are doing. And they said, on the basis of current evidence, it's not clear if LIA provides pain relief at all, or if it has a record of safety equivalent to a femoral nerve block. So not very positive. This paper by Tofdal, just a little bit after that, was one of them, and sorry, this was included in the review, and they found the bottom line is they found no difference in pain outcomes or length of hospital stay between the 2 groups at all. So this is just femoral blocks. If we look at the study, which is a little bit later, this is Carley's study. They took 40 patients. The paper was a blinded study. One group got ropivacaine and ketorolac. The femoral group got a ropivacaine block as well. And the morphine PCA consumption was increased in the group that had the infusion. So it was 48 versus 26 for the PCA usage. And the functional outcome at 6 weeks was better in the femoral nerve group. So the femoral nerve group did better in this study. And what was interesting in this group is both of the groups received posterior capsule infiltration. So whereas we've got the local infiltration competing with a femoral nerve block alone, when you add the posterior capsule infiltration in, the picture is starting to become a little less clear, and you're starting to favour maybe nerve block with a posterior capsule infiltration. So bring in Mike again, and also Ian Harper, who, from the anaesthetic point of view, you could call him a spy in the camp. And once again, this is Joe's handiwork, so just a little advert for him. And they produced their first paper on local anaesthetic infiltration in an orthopaedic journal in 2014. And they managed to get pretty impressive results. They reduced their length of hospital stay from 6 to 3 days. They reduced their transfusion rates, they reduced their cardiac events, and they reduced their 90-day mortality. So this is a manager's dream, essentially. So you can see why this is going to be popular. But if we just take it apart a little bit, are actually any of the improvements that they claimed due to local infiltration rather than blocks? And the reduced transfusion isn't, is it? The reduced transfusion was because they were avoiding drains, they weren't putting drains in, and they were starting to use tranexamic acid. The reduction in their length of hospital stay, well, arguably, a lot of that is due to patient education, getting the physio, getting them up and moving, telling them that they're not going to stay for a week, they're going to be going home after 2 or 3 days, and a consistency of approach. So it may well be that it's the consistency of the approach rather than the anaesthetic technique that's causing those big improvements. So is the kind of LIA enhanced recovery program masking any negative aspects? Well, in the in the 6,000 patients that they presented in that paper, they presented nothing about the pain data. There was no pain data at all of those patients. So although their outcome measures were better, we don't know anything about their pain in hospital during that time. This is a paper by Henrik Kellett, and they were using a similar. Mike Reed brought his regime over from Henrik Kellett, and they were looking at fast-track hip and knee arthroplasty, and you can see pain scores. We'll just take movement are really high preoperatively, but they stay high, and they stay high a number of days after surgery. And there's some really big outliers. This is just the data from the knee, the knee group. So you've got a lot of patients who are really quite uncomfortable after using this technique. And Henrik Kellett's own summary of this was that hips are fine, but he reckons that this technique gives insufficient analgesia after total knee arthroplasty. So this is Henrik Kellett's opinion. And if we take also that the incidence of persistent knee pain can be up to a third after a knee replacement. So it's really sore at the time, and then you have a high incidence of chronic pain. And from this paper, their summary is that the most important independent predictor of persistent pain in the long term is pain immediately after the procedure. So I think we need to look at something that can match LIA in terms of length of stay and hospital discharge, but something that provides better pain relief in the short term. So just this is just a conclusion from the LIA bit. It wasn't really developed with a sound evidence base. We've looked at that. There's very few patients. Arguably, it's not responsible for the length of hospital stay reduction or the complications reduction. It doesn't provide good analgesia, I don't think, and it's not the only way to reduce pain and avoid opiates. Now, something that was quite helpful for giving this talk is that down at the Winter Scientific meeting, this guy, Eric Albrecht, spoke, and I met him afterwards and stole a few of his slides from him. So this is one of Eric Albrecht's slides, and he did a couple of big meta-analyses. There's nearly 1,200 patients in this one, and a negative number tends to favour local infiltration over a block. But this is just looking at local infiltration versus a femoral block. So if you look at the IV morphine consumption and the pain scores at rest over the first 24 hours, there's no significant difference between just doing a femoral nerve block and doing local infiltration. There's a trend towards local infiltration, but no statistical difference. However, if you look at, if you add in a sciatic nerve block to the femoral nerve block, then the numbers become more negative, and on this slide that means that it's favouring a combination of femoral nerve block. The conclusion of the paper was it favours femoral and sciatic nerve block over local infiltration in terms of pain scores and in terms of IV morphine consumption. So blocks are better than LIA on those measures. This was so kind of hot off the press. This is down from London at the Winter Scientific. These were Eric's. This is his conclusion slide. They're concerned that LIA requires high doses of local anaesthetic with a risk of toxicity. That there's lots of different things that are added into the mix for LIA that aren't licensed to be used for that, and that it's inferior in terms of pain relief to femoral nerve block and sciatic nerve block. So we're here to learn about regional anaesthesia today. So let's think about the new generation of blocks. So I'm going to talk a little bit about posterior capsule blocks or infiltration, and adductor canal blocks, which I'm sure you've all heard are, the new big thing in lots of people's eyes. This is the innervation of the knee. So you can see, although the anterior portion of the knee is heavily innervated by the femoral nerve with a little bit of obturator just down the medial side there. The vast majority of the posterior innervation to the posterior part of the knee is from the sciatic, with a small component of the medial obturator coming down just over here as well, the medial branch of the posterior branch of the obturator. So, considering blocks, and let's not bin femorals altogether from the discussion to start with. The original Prospect trial in 2008 was very, very positive about femoral nerve blocks. It was a grade A recommendation from that paper. I'm sure you're all familiar with that. One of the things that's often the surgeons complain about femoral nerve blocks is femoral weakness and falls. And I just wanted to put up a couple of slides to say there's no evidence that femoral nerve blocks lead to falls. People fall after knee replacements for all sorts of reasons. And so this was the a paper with 190,000 patients. 12% of them had continuous femoral nerve blocks, so that's nearly 25,000 patients with femoral nerve blocks. And they said that the risk factors for fall were advanced age, male sex, comorbidities, including obesity and SAS. So they said, contrary to common concerns, there was no association between femoral nerve block and inpatient falls. The only paper that really shows that there is that was positive to say that femoral nerve blocks might cause falls was this one. And if you actually look at the patients that fell in this study, these are the patients that fell. Discard the middle three because they're hips. The top one, quadriceps weakness was denied. They fell walking through the front door. The second one, quadriceps unclear. The third one, again, denied quadriceps weakness, and this was returning home after 3 days. And the other one fell slowly backwards while they were walking the dog. There's just the conclusion of the paper doesn't support when you go further into it and look at the paper. So don't when the surgeon says patients fall because of femoral nerve blocks, they don't. It's because of other factors. I'm going to talk about adductor canal blocks, but this is an interesting paper which again was in Rapham in 2015 and compared adductor canal blocks and femoral nerve blocks with a time to discharge, readiness to discharge criteria. So they looked at both analgesia and ambulation as a kind of combined marker. And at no point along these two curves is there any statistical significant difference between a femoral nerve block and an adductor canal block in time for readiness for discharge. So there is some evidence that femoral nerve blocks are equally as good as adductor canal blocks. Stepping away from the anterior side of the knee for a second, I'll talk a little bit about the kind of posterior capsule blocks and the nerve supply to the back of the knee. You've got the sciatic nerve running down here, so you've got the tibial and the common fibula coming around. Both nerves contribute to a plexus that lies between the popliteal artery and the posterior capsule. There's also a contribution, as I say, from the posterior branch of the obturator, which feeds into that plexus. It's variable in different patients, but they always form this plexus deep and around the popliteal artery. This is Christian Egler. Christian Egler developed some of these posterior capsular blocks, and I'm hoping he's going to be like the James Bond and kill the baddie from Lear up the road. And the reason for mentioning him is that I wanted to put up this slide just to advertise RAUK. This year is down in Swansea, and Christian's organising it. We've got some slides later that Jono's going to put up with all the speakers on and everything, because that was hot off the press this morning. Going back to the posterior capsule, this is a splendidly named SPANK block. This is a block that was done without ultrasound, and the idea is to put the local anaesthetic around the plexus I've just been talking about and deep to the actual sciatic nerve. So you can see the tibial branch is right up here, unstained with any dye, whereas the dye is sitting in the posterior capsule of the knee. This was a pilot study of 20 patients, and they said there was significant pain relief without a motor block. And you can see why that would be from this cadaver kind of study. This is what we do in Sunderland, and this is an ultrasound-guided version of that. You can see this is a tibial branch here, this is a common fibular branch, and we put the local anaesthetic down. This is a posterior capsule just coming down the back here, and the local anaesthetic goes deep to the artery, between the artery and the posterior capsule there. It's an ultrasound targeted block. We infiltrate, we put the local anaesthetic where we know the nerves lie, we don't see the nerves. And we tend to come in from the lateral side, but arguably you could come in from the medial side as well. So that's where we put the local anaesthetic. And we can have a look at that in the scanning section later, and we can go through that. We found that this was 2014-15 when we were using a combination of femoral and popliteal sciatic, and you can see our median length of stay was quite short even then. We managed to get it down to 2 days, and I have to admit that it only just flicked down to 2 days. It wasn't a hugely dramatic reduction. But this was when we added the posterior capsule rather than a sciatic nerve block into the mix. Our pain scores between the sciatic nerve block group and the posterior capsule nerve block group weren't significantly different. So we're not increasing mobility at the expense of analgesia. And just to show you that the morphine consumption over the 2 days, the posterior capsule infiltration actually used less morphine over those 2 days. I'm not sure how significant that is, but they certainly weren't. We certainly weren't using a lot of their oral morphine. They weren't getting a lot more breakthrough pain. So that's kind of posterior capsule. I'll come back to it a little bit, but this is the adductor canal block, which is very popular, very topical, and you can see why it works. And the nerve supply to the knee is complex. This is the anterior innervation of the knee. The nerve to vastus medialis is probably very important. This is coming down in the adductor canal, or at least in proximity to the adductor canal. And the saphenous nerve is the other nerve that supplies the anterior surface of the knee, and is going to be relatively consistently blocked by an anterior approach. This is a paper that first kind of got me interested in adductor canal blocks. This came out in 2015. And I like this paper because what they did is they took patients who'd had a knee replacement, and they gave them multimodal analgesia and opioid, and then 24 hours afterwards they gave them either a femoral nerve block or an adductor canal block. And they measured the motor strength and the voluntary contraction of the quadriceps before and after the block. So you can see the red dots here are the femoral nerve blocks. So after the block, their power reduced to 16% on average of what it was before they had the block. So the femoral nerve block was making their quadriceps weak, no doubt about it. But the adductor canal blocks are these green dots up here. And when it comes to voluntary contraction, they were nearly twice as strong after they had the block as they were before, because they didn't have any pain in their knee, so they could voluntarily generate a much stronger quadriceps contraction. And they used a functional measure called the timed up and go test, where they get up out of a chair, they walk 3 meters, they turn around, they come back and they sit down. And after the blocks, 7 out of the 25 of the femoral nerve blocks couldn't do that, whereas all of the adductor canal blocks could get up and walk around. So they were stronger when it was measured, they were better functionally after the adductor canal blocks. There was limited pain data presented in this paper, but you can see that the pain scores between the two groups seem to be no different over the first 2 hours anyway. So it's a really kind of promising block. hot on the heels of that paper, there was some kind of discussion about what's a true adductor canal block, where is the adductor canal, and you can see this was a dissection of the adductor canal revealing dye coming down the adductor hiatus, and they said that in summary the anatomical dissections that they used, which injected into the apex of the femoral triangle, so this is really quite proximally, did spread down into the adductor canal. So if you think of the femoral triangle is the medial border of sartorius, the medial border of adductor longus. It's quite a way down the thigh, actually, the apex of that triangle. But a true adductor canal is even further down that. But even a relatively proximal block will spread down into the adductor canal. This paper, Marianne's paper, again in Rapham in 2015, showed a similar picture. Blocks done in the mid-thigh, slightly higher up, had 100% block success. They measured block success by blocking the saphenous nerve, so they were just really looking at the saphenous nerves. Whereas lower down in the leg, the success rate was a little bit less. So some of the evidence is suggesting that you should go higher up in the femoral triangle. Some of it's suggesting that you should go lower down. And this paper was just in Rapham again in December 2017, the same issue as the big review, and they were looking at cadavers. This is Benson and Jens Borglum. So they're well published on this type of stuff, and they injected dye either into high up in the femoral triangle or low down into the adductor canal, and they aimed to evaluate the spread of the dye in the two after injection into the two areas, into the whether it went through into the popliteal fossa, which is one of the postulated kind of mechanisms, or and whether that happened if you went more proximally as well. So just to kind of clarify that, this is the femoral triangle here. So the medial border of sartorius, the medial border of adductor longus. This is your more proximal injection. So a proximal injection we're counting as mid-thigh. So this is your anterior superior iliac spine there. That's the top end of your patella. So the apex of your femoral triangle is about halfway between those 2 points, whereas a true adductor canal block, this is the adductor hiatus here marked in green, is much further down here. The difference anatomically is this cross section is the blue arrow. You can see this is the sartorius muscle here. Yep, this is adductor longus, adductor brevis, and the arteries lying, the superficial femoral arteries lying under the sartorius muscle, and we've got the saphenous nerve in the kind of magenta colour and the nerve to vastus medialis are all lying very, very close together subsartorially. In the adductor canal, however, further down in the leg, you have this thing called the vastoadductor membrane, which connects vastus medialis to adductor magnus, and you can see the saphenous nerve lying here, and the nerve to vastus medialis lying further out. So, if you do a distal injection, what you will get is, and they found this in all their dissections, you get spread through into the popliteal fossa. So a lot of your analgesic effect is coming from the local anaesthetic spreading through the adductor hiatus into the popliteal fossa and blocking those nerves to the back of the knee. So if you want to block the nerves to the back of the knee, then this is a better approach. But there was another paper that showed you can get sciatic involvement relatively commonly. So you will get motor block, sciatic motor block from a distal adductor canal block. The saphenous nerve here has pierced the vastoadductor membrane, so it's lying out with the adductor canal. And the nerve to vastus medialis is quite a distance away, and it's carried within its own sheath, so it's completely separate. So you're likely or more likely to miss both of those nerves with a distal adductor canal block. This is just showing, this is the dye coming through from the distal approach into the back of the popliteal fossa. So here's the sciatic nerve here, not stained by the dye. The dye is deep, so the dye is sitting around that popliteal plexus. This is Goffin's, where it came through. They used 20 mils rather than 10 mils, and you can see there's local actually in the sheath of the sciatic nerve. So they with 20 mils, they were getting a sciatic nerve block, which is not really what we want for a knee replacement if we want to keep them mobile. The proximal injection, so this is when we say proximal mid-thigh, it always spread into the adductor canal, so you will get an adductor canal block. It didn't spread proximally enough that it reached the femoral nerve, so you won't get a femoral nerve block. And it stained the saphenous and the nerve to vastus medialis, as you would imagine in all cases. So coming back to the initial review, which I was a bit scathing about at the beginning, they concluded, or one of their conclusions was, if you're going to do an adductor canal block, then a block in the femoral triangle seems to be more appropriate than doing a more distal block. I would say that if you're looking to get spread through into the popliteal fossa, then why not just put the local directly into the popliteal fossa with a posterior capsule infiltration? A combination of an adductor canal block and a posterior capsule infiltration block would seem a sensible combination, because you're going to get saphenous, you're going to get nerve to vastus medialis, and then put the local where you want it to go at the back of the knee. I'm always slightly sceptical of any block where you put local distal to the site that you want it to go and expect it to spread, when there's an option just for putting it where you want it to go. That said, there's very little evidence. There's one abstract that was presented at ASRA, and which compared femoral nerve block and adductor canal block and posterior capsule infiltration, or what they call the IPAC block, to adductor canal and posterior capsule infiltration, and they found that the adductor canal plus, rather than the femoral, were more mobile, and that their pain scores were as good. So I think this would be a reasonable approach to a kind of fast-track blocked nerve block strategy for knee replacement, but there's not that much evidence. So kind of coming to an end, really. Blocking this paper was anesthesiology just last year. Blocking multiple nerves, they found blocking multiple nerves was preferable to blocking any single nerve or infiltration, and the combination of a femoral nerve and sciatic nerve blocks appears to be best overall. But if you look, this is quite an interesting diagram. The big dots show this is femoral, this is PCA, PA is periarticular infiltration. The size of the dot shows you how many studies have been done. If the line's red between the comparison, it's likely to be biased. If it's green, it's pretty good. And you can see, if you look at, this is the combination of this is adductor canal block, this is adductor canal block and sciatic. There's hardly any work been done on this, and certainly there's no lines going to, to compare it with infiltration. So I think we're still really at the kind of level of looking at what we think makes anatomical sense, and going from there. So in favour of blocking, I think if you have a blocking sort of setup, and you have a block room and you can get patients down quickly, blocking rather than letting the surgeon infiltrate may well speed up your list. There's the kind of safety aspect. There's some similarities between infiltration and blocking. Essentially, this needle is going into the same space as this needle is, but this needle is wielded by the surgeon without ultrasound and is pointing directly towards the sciatic nerve, and they're going to be infiltrating there. And this nerve is wielded by someone who you hope has a bit of skill with an ultrasound machine and is putting the local exactly where you want it to go. So I would argue if it was my knee, I'd rather have this approach to putting the local there than that approach. And as a side, we know the incidence of sciatic nerve damage is quite high after knee replacements anyway. In favour of blocking, we know that there's good evidence that we can now keep patients mobile. They can be mobile and be blocked. We just need to put the local in the right place. So I would argue that that's quite a good strong argument for blocking. And that's it. Thank you. Any questions?